I think we are live now. Everybody in the waiting room should be getting transferred in, so I'll wait just a second while everybody's moved in. And I just want to welcome everybody. I am Sarah Ashman, your host tonight, and I have Dr. Deorge Papanicolaou, who is a physician at Ultra Wellness Center in I think it's the Boston area. Is that correct?
Actually, it's Lenox, Massachusetts, about 2 hours west of Boston, near just about on the New York State border.
Okay, perfect. A little bit about Dr. Papanicolaou. He's a graduate of the Philadelphia College of Osteopathic Medicine. He's board certified in family medicine from Abington Memorial Hospital in Pennsylvania. After graduating from his residency, he joined the Indian Health Service, worked on the Navajo Reservation for 4 years, and served as the outpatient department coordinator. In 2000, he founded Cornerstone Family Practice in Rowley, Massachusetts, where he practiced with a philosophy centered on personal relationship and treating the whole person, not just the disease. He called that philosophy whole life wellness. And over time, as the healthcare system made it harder for patients to receive this kind of personal care, Dr. Papanicolaou decided a change was needed. So he began his training in functional medicine through the Institute of Functional Medicine. In 2015, he established Cornerstone Personal Health, a practice dedicated entirely to functional medicine. And in August 2017, Dr. Hyman invited Dr. Papanicolaou to join the Ultra Wellness Center. Dr. Papanicolaou lectures on a variety of topics, including functional nutrition, food as medicine, the gut-brain connection, attention deficit hyperactivity disorder, functional fitness, and weight control. And tonight he is going to be so generous with his time to walk us through his extensive experience with Lyme disease. And I think tick-borne diseases in general. Is that correct? Not just Lyme?
No, I'm going to be focusing mostly on just some of the practical issues of just dealing with Lyme.
Sure, great.
I'll bring in some other concepts, but mostly just Lyme.
Great. So if you're listening, we do have time allotted at the end of the webinar for questions. So if you have questions, you can type them into the Q&A on your device if you're on a computer or a mobile phone using the Zoom app. And we will get to those questions at the end. We'll have 10 or 15 minutes left over where Dr. P can go over that. All right, so I will go ahead and turn it over to you and take it away.
Okay, well, thank you so much, Sarah. It's a pleasure to be here and talk about Lyme disease. A little bit more about myself. My practice was a traditional family practice, and I did that for 18 years. I had my practice, and it was about before I closed it, which was at the March of this year. I prior to that, about 4 years earlier. That's when I just realized that primary care medicine was just moving in the wrong direction. We weren't able to treat health. We were really treating acute disease, despite the fact that the United States spends more per capita on health than any other country in the world. We're ranked 13th amongst developed countries for overall quality of healthcare, and most of it is because we just don't do well with chronic disease, and we don't treat health. So when I made all those connections in my brain and I discovered functional medicine, I realized that all these years as I've tried to develop a model of whole care for the person treating health, that there was this superhuman race called functional medicine doctors creating this incredible paradigm. And I just felt like, wow, how did I miss this boat? But I didn't miss it. I got on it, and I really transformed my practice, and my whole understanding of medicine completely shifted. So I came, to this whole world of functional medicine, and it's been a whirlwind of education. And coming to the Ultra Wellness Center really transformed my understanding of what we do, not only to keep people healthy, but the complexity of dealing with chronic disease when you're trying to get to the root cause. And so I was just really thrust into the cauldron, because we have people that come from all over the world who have been treated in multiple different places looking for answers because they haven't gotten them. They keep getting treated for known diagnoses with drugs that will either treat the symptoms or suppress the disease, and they're not getting better. And nobody wants to look at some of the deep root causes of the disease. And when we have patients come like that, we have very complex patients with very complex symptom sets that we have to sift through. And so when I was asked by Carolyn Salvi, our Vibrant rep, to talk about Lyme disease, I'm really coming at it as a doc who is really growing in his knowledge and working through some of the fundamental questions that people that maybe been treating Lyme disease for many years may be working through. Maybe they've worked through them. I don't think so. I think these are fundamental issues that still need answers. But I'm going to share with you tonight, my practical approaches to dealing with really complex patients who have many, many symptoms going on, and oftentimes Lyme is one of them. And I have to tease that out. And the landscape for doing that is very complex. And let's see if I can get okay. So, yeah, we'll go over here. I just want to say a couple things about just a basic history. So what a lot of people don't understand, it has been around for thousands of years. It's not new. It wasn't some, government conspiracy on Plum Island, right outside of Newburyport, where bacteria got loose. There is a myth, you can look it up on YouTube, that's where Lyme disease came from. No, it's been around for a long time. They found Lyme in a 5,000-year-old mummy. So 5,000 years ago, we know at least one person was exposed to it. And now we know that there's about 320,000 new cases per year. And that's a lot. That's an epidemic. And it's everywhere. It's in Europe. I have plenty of patients that fly in from Europe for evaluation for chronic disease. And I've seen it in multiple different countries. So it's everywhere. It's been around for a very long time. It's a spirochete, much like syphilis. It's very smart, and it can do a lot of damage while hiding out in our bodies. So it's a small tick. There's big questions, and there's been no easy answers. And that's what we talk a lot about here at the Ultra Wellness Center. I talk with my colleagues. We have more questions than we have answers. And we have frequent conversations about how do we make the diagnosis, how do we treat, how long do we treat, and what do we treat first if a person has multiple problems, which could be heavy metal toxins, could be mold and Lyme, and even have significant cognitive decline. I have several patients right now that have come to me with Alzheimer's, and actually two of them have significant chronic Lyme. So we always have to figure out, where does Lyme fit into the picture? So what we all have heard, and it is true, this Lyme tick isn't in the bullseye because it's very difficult. It's a very mercurial creature, and it's very difficult to pin it down, and it can imitate lots of different diseases. So when I see patients, it's this complex of symptoms, that we have to sort of see these symptoms that come. I can have a patient with almost all of these symptoms, and I have to somehow figure out, what's going on, and try and decide if I'm even going to test for Lyme. And then later on, I'll talk to you about, once I decide to do that, what I'm going to do. But these are some of the diseases that have been known to masquerade as Lyme. There have been people with these diseases who've then been treated for Lyme and have found that they are healthy people. And so it's a long list. Some of the scariest disorders that we can think about are on here: ALS, Alzheimer's, dementia, Parkinson's. So as you see this list, it's pretty significant. So where do I start? My goal with all of my patients, no matter what I'm thinking about, but very specifically with Lyme disease, is to, get a pretest probability of how likely is it, do I think a person has a particular disease I'm about to test for, whether it's Lyme or anything else. So in functional medicine, that is so fundamental to what we do. We're always asking the question, why? And I could be treating a person for 3 months, 6 months, they can be getting better, they're not completely better, and I'm still asking the question, why? So getting all of the information, so when a patient comes to see me here at the Ultra Wellness Center, they actually fill out this MSQ. This is a multiple system questionnaire. And basically, they fill this out, and it can be scored. And a score less than 10 means you're pretty healthy, 20 to 50, mildly ill, 50 to 100, moderately ill, and above 100, you're pretty, you can be pretty debilitated. So we start collecting symptom sets and start getting a picture of what's going on. And we take a long time to do that. I spend an hour with the patient sifting through all of this. I'm going to come back to that slide. What I will then do is, as I'm interviewing the patient, getting their symptoms, I'm also going to be looking to create a timeline of events and then try to categorize all their symptoms by system. I'm not going to try to categorize it by diagnosis. I'm going to try and categorize it by system, so that when we talk about assimilation, we're talking about digestive processes, the breakdown of food, absorption, gut function. When we talk about defense and repair, we're talking about immune issues. So over here, gut issues, people that have belching, bloating, distension, known IBS or inflammatory bowel disease. All of these are connected. And so so I get everybody's symptoms, I get their conditions, and I put them into different biologic systems. I collect their current lifestyle patterns. And then I start to determine what are some of the antecedents that may be leading to some of these conditions. Were they C-section? Do they have genetic variants and SNPs that we know about, or family history? What events may have triggered their symptom set? Was there a tick bite? Was there a previous diagnosis of Lyme? Was there a traumatic event? Antecedents here would also be like a standard American diet, antibiotics. What are the things that keep perpetuating disease? I have to get all this information, and then I have to categorize it so that I can begin to get a picture of what's going on, and then what do I have? What can I make decisions on based on history and symptoms, and then physical exam, and then once I have all that information, then I ask myself, what's missing? And what tests do I have to run to get to what I need to get to? And that what's missing is really based on, what do I think is going on? Do I suspect that one of the root cause problems is a stealth infection, whether it be Lyme disease or Epstein-Barr virus or echovirus, or cytomegalovirus? If I think it's any one of those, root causes, I want to know when I go to get the test, how sensitive is the test, and what level of pre-test probability do I need to have to interpret the test. This becomes really important in Lyme disease because the testing is just, the sensitivity and specificity is not where it needs to be with the standard testing that we do. And we'll be talking about that later. And the timing. One of the points I want to make is that I'm going to be really talking about chronic Lyme disease. I see very little acute Lyme disease in my practice. I see people with chronic Lyme disease. And so chronic testing in chronic Lyme disease is very difficult. And so you have to have a very high pretest probability, because it won't be unusual for the test to come back negative or equivocal. And then you have to make that decision. Wow, if I really think they have Lyme disease, I may still treat. And that's an important point. So this is an example of what a functional matrix will look like. But I'm going to step away from that for a second, and I'm going to take you back to the MSQ. So if a person has 110 on the MSQ, they're pretty sick. And I probably will skip doing an MSIDS, because at that point, I already have a really high suspicion that they have, that I'm going to need to test for Lyme disease, that you won't be able to go forward not testing for Lyme disease, particularly if the person lives in an endemic area and they have a history of a tick bite, or they have a very high probability for exposure. If they don't have that high of a score and their story is iffy, they can't recall a tick bite, they might not have the highest risk for exposure, but there is some, then I'll do an MSIDS. So this is a multi-systems inflammatory disease syndrome. This is developed by Richard Horowitz. And it's a test, it's a screening tool that actually has been validated. And it has been proven to be able to separate out patients with inflammatory diseases and other infections who have Lyme disease. And so I will then use an MSIDS. And if they score greater than 46, then that really increases the likelihood and starts pushing me closer, to a 75% pretest probability that this person has Lyme disease. So the MSIDS, the MSQ, the MSIDS, and then are two tools that I use to determine my pretest probability. And then the real, and this is one of the studies that looked at 537 individuals being treated for Lyme disease, and then 999 participants online that self-identified as either being healthy, suffering from Lyme, and they all completed the Horowitz MSIDS. And what they're able to determine using factor analysis is that there are 6 underlying latent dimensions: neuropathy, cognitive dysfunction like memory loss, slow thinking, brain fog, musculoskeletal pain, and fatigue, that consistently demonstrate the ability to separate people out and identify them as having Lyme disease. So it's a validated test, and it's a piece of research, and I use the MSIDS like everything else. All my other tools, none of them are perfect, but when I put them all together, I can make that I can see that picture happening. So I don't actually do this anymore. I do my functional matrix, but now I have it on a PDF and I can actually type it in so it doesn't look so chaotic. But I think this is pretty cool looking. Basically what I do is while I'm with the patient, I start, putting their conditions in. So this particular patient that we'll be referring back to several times came in, and he was a young gentleman who was bit by a tick and had only 10-day treatment. Slowly over years, leading through college and into 25 years old, he just continued to develop these symptoms of brain fog and cognitive slowing and then joint pain. And then he really began to have some different neurologic involvement with neuropathies and numbness and tingling and muscle twitching. So I put together his matrix, and we had conditions in every one of the categories. And what I do is I draw these arrows so patients can see how everything is connected. And in his particular case, he just had multiple antibiotics as a kid, so he already had underlying gut issues before he even had been bit by a tick, which probably created some inflammation and immune dysregulation and just a disordered gut microbiome that would really leave the immune system open for attack by any number of stealth viruses. But Lyme disease would definitely wreak havoc. So I put this whole picture together. I looked at his lifestyle pieces, and I started to think, you know, there's a strong likelihood that he has chronic Lyme disease based on all the information I had here. He also was likely that he had SIBO, small intestinal bacterial overgrowth. There's likelihood that he had exposure to chemicals on the job and also mold. So we were going to be testing for all those things. But when it comes to testing for Lyme, I always feel like I'm opening up Pandora's box. So I'm really careful to try and get, particularly if it's chronic Lyme, I like to get my pretest probability up to about 75% when I'm going to do the testing. Because then I know if I get a negative or equivocal that I'll still feel confident enough to go ahead and treat. So what are the tests that are available? Well, currently, you know, the recommendation is they do two-tier testing with an ELISA, which is an indirect test, and then a Western blot, which is another indirect test. So in my mind, you're just multiplying your opportunity for error because there are issues with timing, particularly with the ELISA. ELISA can be a really sensitive test if the timing is perfect. It certainly isn't a good test for chronic Lyme disease. So I don't even think about it in chronic Lyme disease. The Western blot, currently in standard labs, you know, only tests for one species and very few antigens. So it's just by that, it's not a very sensitive test. It's not going to be that very helpful. And then the Western blot technology, basically you're separating out, you're embedding the antigen into a gel. These antigens are charged, and then the patient's sera is then passed through this gel, and the antibodies are going to separate out according to charge if they attach to an antigen. So a couple issues. One is that the gel result is very sticky. You can have a lot of antigens that are part of the sera and the cell that will have charges that will land on an antigen and have nothing to do, it's just junk. And so you end up with these really, really wide bands that are really more junk than they are antibody. And then you have human readers. So they've tried to automate reading, but they can't do it very effectively. So you have human error with a test that already is introducing error because of how the antibodies will migrate. So Western blotting, particularly in a conventional lab, is not very sensitive. And you can get a lot of false positives, so it's not very specific either. So the Immunoblot is basically is a Western blot where they actually will blot the gel, and the antigens then become embedded in the paper, and then the patient's sera is passed through the paper. So this just actually introduces more variability. There's limitations in separating the proteins by size. We already talked about that in terms of charge, but when you have to reproduce the gel antigens in their appropriate sequence onto the paper, and that introduces a possibility for error. So this again is a test that doesn't provide the sensitivity and specificity that we're looking for. So I don't do that test that often anymore. Then there's the Vibrant Lab has their immunochip. So with the immunochip, they're basically using a microchip that has, and these microchips are placed in separate wells. And so you have multiple chips. Each chip is one person. On that chip, you can test for multiple antigens in multiple species. And it's not embedded in a gel, it's epoxied on. And so there's no, it makes it very easy for the antibodies to attach and very specifically to the antigens. And then these are machine read. so that there's no human error. There's accuracy and reproducibility, and the sensitivities and specificities are above 90%. So those are indirect tests. That's just looking for the body's response to the organism. It doesn't tell us that there's an organism there. Particularly, and that's a particularly controversial issue when it comes to treating chronic Lyme, because you're going to get IgG positive. And if you have IgG positive, that means that you've been exposed. There's going to be a question about whether the person, it's actually active or not. And again, that's where a really good story and working through all the symptoms and the conditions the patient have helps me, as close as I possibly can, determine if their Lyme disease is active. So I have to get a lot of history. I have to track their symptoms over time and get to that point where I can confidently test and make decisions. So direct testing is when we're looking for the organism itself or traces of it. And so this is, to me, this is where the holy grail is, getting direct tests that are really sensitive and effective. I should say sensitive and specific. And so the direct test that we typically use is the PCR test. So this is basically, getting looking for the organism or antigenic material of the organism in the person's sera. And so we then use antibodies against the antigens, antibodies against the antibody that's attached to the antigen, and you're able then to determine whether or not there is the Borrelia DNA or any other antigenic material related to it. So you're basically taking person's cells, spinning them down, and then breaking apart. Well, you're not really breaking apart, but then you're going to try and see. You're going to use antibodies that have been cloned to go after the human cells that the human antibodies would attach to the antigen. So it's a direct test. It's being used more and more as the technology improves. It's becoming more sensitive. But with Lyme disease, because it can suppress the immune system, because it can hide, it's not yet as sensitive as it needs to be. So then there's the multiplex PCR chip from Vibrant. So Vibrant does a couple things that are really cool. One of the things that they do is they take the person's blood, and we do know that the Borrelia can hide inside cells. So Vibrant, actually, when it's spitting down the blood, use these these very minute glass balls to break apart the cells. And in doing so, breaking apart the Borrelia if it's inside the cell and creating more antigenic material. So that's something that no other PCR does. And then they amplify it several more times so they amplify that genetic information several more times than standard tests do. So you are able to take very, very small amounts of antigen. Then you can amplify it using RNA replication, and you can then, at very low levels of antigenic material, using amplification, breaking the cells apart, getting more antigenic material, get a very sensitive test. So those are the tests that are available. None of them are perfect. I've migrated to using the Vibrant test because of the reasons I've mentioned. Then there's some other tests that I do. There's another direct test called Elispot. It's an enzyme-linked immunospot, and what it does is it's going to actually look at the T cell response to Borrelia. So when Borrelia is active, your immune system is going to make T cells, particularly T1s. And those T1s will when they come in contact with Borrelia, they're going to release interferon gamma. And interferon gamma has an antigenic pattern, which can be, that antigenic pattern is bound by an antibody. And if you can measure interferon gamma, one cell of, you're measuring very, very, very low levels of potential Borrelia. So it's a good test in theory to determine if there's activity. Because if there's no Borrelia active, then there will not be T cells, and you'll not be able to pick up on any interferon gamma. It's a test that's actually used in lots of other contexts, not just for Lyme. It's been proven to be very sensitive. I do use it. It's not perfect for Lyme, but it's one of the other pieces I use to help me make a decision if the person has IgG and it's equivocal, and I get an Elispot and it's positive, then I'm going to tend, given what I understand about sensitivity and specificity, it will push me closer to wanting to make that diagnosis of Lyme disease. So Elispot. So currently, what I use is the Vibrant tick-borne comprehensive test. I use Elispot, and I also use a CD57. So the CD57 is a cell line that can be diminished when a patient has Lyme disease. So the CD57 lymphocyte, when that data has shown that people with Lyme disease this cell line is going to be suppressed, and there have been actually several studies that have shown it. And when you get down below 60, then that's enough suppression to make you suspect chronic Lyme. Below 20, most experts will say that's Lyme, that until proven otherwise. So if I ever see somebody with CD57, and that's actually one of my screening tests before sometimes I'll even do Lyme testing, is I'll get a CD57, and if it's below 60, then I'll go ahead and do the Lyme testing. So CD57 becomes sort of a screening test that I use along with my clinical assessment. So the testing that I currently use to try and get the whole picture is the Vibrant Comprehensive Tick-Borne Analysis, a CD57, and plus or minus the Elispot. And so we look at the comprehensive panel that Vibrant offers. It's multiple species with multiple antigens. And it's really important to know that there's multiple species. It's Afzelia, Afzelii, Guerinii, and Burgdorfii. And they also can test for Myeloid, Hermsii, and Terracate. All of these can cause Lyme. And if you're only testing for Borrelia, then you could get a negative test and it's another species. So going back to my patient, I did do the comprehensive panel, and I'm just going to show you the part that was positive. So let me see if I didn't put that slide in, but this is not positive by CDC criteria, but it is positive for Lyme using Vibrant criteria. So whenever you do that, whenever you see that a company has their own criteria, and it's not CDC standardized, you're left with a little bit of a dilemma as to what you're going to do. I think that with Lyme, we have to be really careful about making our diagnosis, particularly when it's based on IgG, because that's why I try to get as much information as I can that clinically makes me seriously consider that Lyme is part of the condition complex. It might not be the only thing, and it rarely is. So this particular test in this gentleman it didn't overwhelm me. It was positive, but his CD57 was 29, and his clinical symptoms included brain fog, neuropathy, fatigue, disordered sleep, and joint pain. So he had the 6 that are on the MSIDs, and the studies have shown correlate very highly with chronic Lyme. So I started seriously moving towards treating him, in which I ended up making the diagnosis of Lyme disease in this patient and treating him. So just to summarize on my current protocol, so to speak, I will say one thing, that nothing about what I've just said to you in my protocol, all the touch points, getting a really thorough clinical history, and then getting my pretest probability, then trying to choose my tests wisely with the CD57, the most sensitive and specific Western blot that I can choose. None of them are perfect, and it becomes a real sense of experience and clinical judgment, oftentimes, of whether this person is going to have Lyme disease. It's rare that it is just Lyme, and it's rare that it is going to be black and white, even though my current slide is black and white. So, and the other thing about what I'm saying to you is all going to change. I could give this, hopefully I will, I'll give this this webinar 3 months from now, and I'm gonna know more. I'm gonna have experienced more, and I may be doing things differently. There may be different new technology on the market, and I'll be going down a different path with how I make my diagnosis, what tests that I use, and then ultimately how I treat. So when it comes to treatment, and I'm going to just talk briefly about treatment, it's really it's just not the bugs. If you can just excuse me for 1 second, I'm going to get a glass of water. It's really it's not just, it's more than the bugs. I have a rare patient where it's just Lyme disease, but Lyme is playing a critical role because it compromises the immune system, and when that happens, it creates opportunity for other things to happen. Like you'll have more sensitivity. It will trigger SNPs, and you're going to be more susceptible to mold. So when I have a Lyme person, I'm really looking. Once I know they have Lyme, I'm looking at mold. Once I know they have Lyme, I'm also looking to make sure that they don't have any heavy metal toxins. Once I know they have Lyme, I'm looking, at their gut, because there's a really strong chance that they have dysbiosis that's also triggering the immune system. And there's a strong connection between Lyme disease and irritable bowel, specifically when that irritable bowel is due to SIBO. Because Lyme disease can actually alter the neurologic connections in the gut, causing dysmotility, usually slowing, which can leave you open to developing SIBO. So it's not infrequently that I have patients that have Lyme and SIBO, which makes their SIBO very difficult to treat. Unless that Lyme improves, it's going to be hard to get that SIBO to go away. Just as an aside, when I do have people with SIBO that aren't getting better despite some real intensive treatments, I start thinking about Lyme. And that will be, again, asking why. It's that functional medicine fundamental. Always ask why. So when somebody's not getting better, SIBO, that would be a reason why I might think of testing for Lyme. And I'll go through my whole Lyme testing protocol. So it's more than just the bugs. It's more than just one condition. It's going to be many things. You have to treat the whole person. So when I'm thinking about treating a patient, I need to think about their social context, their cultural context, their economic context, because it can be very expensive to be treated, particularly as a whole person. When we're going to be looking at your nutrition, we're going to be talking about targeted supplements and probiotics. It can become quite costly. So when I'm thinking about the whole person, I'm going back to my matrix, and I'm thinking about all the conditions that are at play. And one of the before I even talk about it, I'm thinking antibiotics. I'm already thinking I've got to support their immune system. I've got to make sure that I'm supporting their detoxification systems, and I got to treat their inflammation because they're really uncomfortable. So that all is going to happen, and I'm also going to be treating them with antibiotics. Now, I should say antibiotics, and that can be either pharmaceutical, or that can be traditional, or it can be using herbals, or it can be both. But that's the whole person part. I have a conversation with the patient. And as I'm treating the patient, they're completely aware along the whole treatment journey or the whole evaluation journey. I make them really critically aware of what I really feel comfortable with clinically, where are the big question marks, and specifically when it comes to Lyme and to mold, I talk to them about some of the pitfalls and difficulties of diagnosis. I let them know what I think my pretest probability is. I'm really transparent with them because they need to have confidence in their diagnosis, because that's really a big part of them getting better. Because once we start treatment, it doesn't always get better right away. People can get worse, they can hurt, they can have side effects to medications. And if they haven't been a part of the decision-making process all the way through, particularly when it comes to treatment, you're gonna have a difficult time with that patient. And they're gonna have a hard time getting better. So that's why it's so important. I put it as number one: have a relationship, engage them in the process, help them let them be part of, decision making. And that's where, you need to know what can they tolerate in regards to how many supplements, what kind of drugs, so forth. Some people would just, doc, treat me how you think is best. Other people I don't want antibiotics. I want herbal therapy. And then we'll start with herbal therapy. So treat the whole person, personalize the treatment, and then do immune support. My immune support really starts in the gut with everything from bone broth to medical foods that will support good gut function and probiotics. When I think about detox, I think about supporting phase 1 and phase 2. So I'll be, looking at, adding in NAC, liposomal glutathione. I will use silymarin to support liver detox. And if I've done, some heavy metal testing, we might be a little bit more aggressive if they have high levels of heavy metals that could be adding to immune dysregulation. And then I treat inflammation. So inflammation and pain is that's another whole webinar. So when I think about treating inflammation, I think about, everybody that comes here sees a nutritionist. So if there's a lot of inflammation, they go on a anti-inflammatory diet. So we'll put them on an autoimmune paleo diet. We'll put them, it's a big one we use, Mediterranean diet has anti-inflammatory components. We'll put them on a 10-day or 30-day detox, depending on the nutritional status. And so nutrition is a really big thing. We have them eating, anti-inflammatory foods. We may, depending again on their testing that we do, we may have them avoid lectins and legumes, in addition to having them eat the anti-inflammatory foods. I'll use things like curcumin. I will use CBD oil. I work with a practitioner who will actually blend CBD oil with a little higher concentrations of THC and botanicals to enhance inflammation. That particular individual does consults and will customize the blend to the patient's condition and experience with if they've used CBD oil or other anti-inflammatories. He's able to create a blend custom to them. Very effective. I'll recommend ozone therapy as a possibility as well. So that's the general overview of treatment. More specifically, it's a threefold attack. So when I'm treating somebody with chronic Lyme, I do tend to start with antibiotics. I have used herbals. There are multiple herbal therapies out there. They're not any less, they're not any more safe generally than people being on pharmaceuticals. I have as many people having adverse reactions to herbals that I do with traditional antibiotics. They have a different way of working, but they can be very effective. And it really all depends on the patient. So I will typically start out, and I do try to understand, okay, when we're dealing with Lyme, it exists in different spheres. It's biofilms, it's in the cell, it's cystic forms. So when I begin my treatment, I will tend to start by going after the cell wall and the intracellular form, and I will also go after biofilms. So a frequent starting point for me is ceftriaxone and azithromycin, and then how I go after the biofilm is oftentimes dependent on the patient. If I'm also treating SIBO, I'll use biocidin. If they don't have SIBO, then I'll tend to use stevia and serrapeptidase as my starting point. And then I will usually, with chronic Lyme, there's always a question of how long to treat. And, it's extraordinarily variable. It depends on the patient response. And I will actually see my patients back at the end of the first month. I just want to see how they're doing. Sometimes they haven't even ramped entirely up because I have them start things in sequence. So I'll have them start things in sequence. But I want to see them in a month so that I can support them. I can address any herxing. They have access to my nurse and to me in that first month. So if they should herx in that first month, they already have instructions. I give them an instruction sheet on what to do. But I want to be there for them as much as possible as they initiate their treatment. Then, after the, first or second month, we're assessing progress. We're assessing any side effects. We're assessing any progress with any of the other treatments, and we make adjustments in the therapy. Usually at the end of the, somewhere in the first or third month, I'll start treating the cystic form, and that's when I will add in grapefruit seed extract, and sometimes Tindamax. I'll also use rifampin. So you have to attack it on all three fronts, and you can do it sequentially. And my treatment is really a sequential treatment. I should say that I include nystatin the entire time, because most people with Lyme either already have Candida or are going to develop it. So they're on nystatin as well as almost as a baseline drug. And then by 3 months, we know how they're doing, and we may consider switching to an herbal, only because keeping people long-term on antibiotics just has a lot of impact on the physiology. It's not that I won't, but it does have a big impact. And there's also medical legal reasons. Everybody I put on antibiotics long-term for chronic Lyme, signs of consent. So those are some of my highlights for treatment. So antibiotics, herbals, timing, I think I discussed it all. So that's it for my practical approach to some complex questions. The questions are basically, clinically, how do you sift through it? And I showed you some of the tools I use. And then, when you're sifting through it, what am I trying to accomplish? I'm trying to get to a pretest probability. I'm trying to determine how much I think Lyme is a part of what's going on. And I use all my clinical assessments. And then if I'm not quite there, then I want to do some testing. And that's when I'm going to use the testing that we discussed, the Vibro Comprehensive, the CD57. I don't even bother doing the conventional test anymore at all. If it's grossly positive, then I think you can hang your hat on it. But I think there's just way too many false positives. I also think that it's not very sensitive, and it doesn't test for multiple species or antigens. So there's the clinical piece. There's what test am I going to use, and then finally, just my current approach to how I start treatment for chronic Lyme. So just is really an overview, but wanted to just go through some of the touch points and share with you where I'm at in my evolution of treating Lyme. And that's it.
All right. So Dr. Papanicolaou, thanks so much. That was actually really in depth as far as, touching on each of those things and talking about your process of kind of working up the patient, their background, deciding what to do. We have a few minutes left. We can probably get to a few questions. Let me see here. I'm going to just read, let's see. Yes, we will have slides. I think a few people asked that. We normally always do have slides available in the provider portal under the webinar tab. We will have that file available once the webinar link is posted, generally within 24 hours. Let's see. Let's see. So Ashley asked, will the Vibrant Lyme test be able to pick up Lyme or co-infections that are in remission? So are you using this to retest after treating? Because that's a common question. How soon after treatment do you retest, or how many times?
Generally, I don't, because the IgGs can be positive for a long time. That's where the Elispot comes in, because the Elispot, if it is positive at the onset of treatment, will turn negative, because if the Borrelia is no longer in the system, or we get to a point of immunotolerance, then you won't have T cells that are directed towards the Borrelia, and that test will be negative. So if I am going to test and I had a baseline Elispot, I'll use that to follow. But I don't retest IgG. I treat. I determine my treatment and cessation of treatment completely on symptoms.
Okay. Let's see. What if the patient is just positive for the VIS-E1 IgG? That very first. So when you showed your slide with the
So as I said before, that was not an overwhelming test for me. This patient, and the reason why I chose this patient is because his clinical picture is what I just wanted to. There's always this question: can you really diagnose Lyme as clinically? You always hear that it's a clinical diagnosis, but it's very hard to make that diagnosis. What really that particular test helped, I would not make it on a 1 positive. And I should really make this point. I don't make my decision to treat solely on the test unless it meets, unless it's like I have a CD57 of 18, and it's an equivocal, like this gentleman had. To me, that was an equivocal test with the CD57 of 18, of what was it, 29. and the 6 major symptoms. That's why I chose it, because he met the criteria I needed in each of those touch points, each of those difficult decision-making points.
Great. Okay. Let's see. What do you do for herxing?
So it all depends on the individual, but I've had success. And again, there's multiple ways to do this, and it all depends on how bad a person's herxing, whether they're herxing for a long time, whether they're cyclical herxers, because some people are. So for an initial mild to moderate, I will have them use a lemon juice concentration to get some alkalinity, and I've had good success with that, and also using Alka-Seltzer Gold. They both will create some amount of alkalinity, and that can, I've had a lot of people have good relief with that. I use, sometimes we'll have to use, we'll up their anti-inflammatories, we'll use CBD oil, I may use low dose naltrexone, and sometimes we'll actually interrupt the treatment.
Great. Okay. And then, so someone had a question when you had said that herbals are not safer than some of the antibiotics, or and so like specific.
I shouldn't.
As far as
I really didn't mean to say safety. I should have really said adverse reactions. They're they're potent. These herbal remedies are potent, and they need to be. But sometimes people are sensitive to the herbs that they're taking in and have some difficulty with them. Again, anecdotally, at the same frequency as people have with their conventional antibiotics.
Great. One last one, because we have to wrap it up. But I think this is probably a commonly asked question as far as Lyme and tick-borne testing goes. Do you do provocations for testing? I know that this is one of those things that there are people who say, yes, you always should, no, you shouldn't, or no, I don't, or it's not important. So what's your take on this?
It's not currently my practice to do that. I think it's, I'm not sure that there is enough data to support it. And it's not my practice currently to do that.
Great. Okay. So thank you so much, Dr. Papanicolaou. We are, always better off for having learned on these webinars, and definitely the information you covered tonight was incredibly helpful. If you are listening, the webinar link will typically be posted within 24 hours on our portal, as well as an email that will go out that will have the link included tomorrow. And the slides we will try to have up there as well when the recording link is put up. So thanks everyone for coming tonight. I really appreciate you, listening in, joining us for this. And I believe in June, we have another webinar on Lyme, a little bit different take, a little bit different perspective. And so we'll be sending out some invites for that coming up here in the next couple of weeks. So thanks, Dr. Papanicolaou.
Thanks, Sarah, for having me. I appreciate it.
Absolutely. Thanks, everyone. Have a great evening.
All right. Good night.